Sienna.
Thank you, Mr. Chairman, and thank you for your testimony. The point of the legislation, if I could just use an analogy, and I'm going to use specifics, a 35-year-old mother of two has gone to her OBGYN for 10 years, independent practitioner. Under this market, she gets pregnant for a third time, and she goes to her doctor, no longer independent. It's a good chance that bought out by a major hospital system. House Bill 1622 would say that in spite of the fact she has a high-mark insurance, and now this doctor's a UPMC employee, she wouldn't lose access to that physician. Without this, though, and these contracts set to expire, I mean, Paula, it's pretty safe to say that she would be forced to sever that relationship with that doctor if it's an employee, right?
Okay, you've got a lot into that question.
I tried to use a hypothetical because
it's a
pretty safe.
hypothetical. I mean, let's start with obstetrics and physician practice acquisition, as a lot of that evolving as this state grappled with medical liability. Had hospitals not supported acquisition of obstetric practices, we would see far fewer than the 97 obstetric units that we are down to in the state. But that said, practitioners prior to acquisition could choose to be participating or not. Over the course of my employment with employer coverage, I have had practitioners who have chosen not to, independent, not to contract, and have had to make those decisions. Those decisions are tough, and that's the area, one of the areas of what's an adequate network, what's adequate in terms of disclosure to individuals about who's participating or not, that we need to have a more balanced conversation between practitioners, the insurers, facilities, and the regulators. We do, at the analogy you present, the individual might have to choose another source of care.
It's a couple testifiers alluded to this bill is only directed towards IDNs, and it's not directed at all hospitals. But in my opinion, the community hospital that I'm very proud of in Beaver County isn't trying to restrict access for certain insurers, almost driving out customers to shift market forces. I mean, how many of your participants aren't willing to contract with insurers, or how many, we heard from Geisinger, an integrated delivery network that contracts with everyone. It's under my impression that most of your community hospitals aren't interested in driving away customers. They're willing to accept everyone. So this apples and oranges argument that this only is a targeted approach, we should be doing it for everyone, I would just say that, and ask you, unless I'm wrong, most community hospitals aren't pushing away patients and denying access.
There are lots of variabilities in how providers and health insurers contract, and I would tell you as a trade association, we're not privy to those contractual terms because they're proprietary, they're negotiated. So I couldn't really give you clear statistics on the practices in those ways. What our concern is in the bills, Representative, is that they are saying an insurer could force a network to do something. At the same time, there's no requirements back to the insurer. And that's what happens when you get into any willing insurer or any willing provider. You are really inserting into what should be a negotiated contractual practice. We have to then look at other state laws around antitrust, around unfair insurance practice, to see if the parameters to make sure that that balance is there are working. If they're not working, then we should be addressing through those parameters.
You may or may not be right, but I don't think any of those solutions solves the problem of severing relationships between patients and doctors, which is the point of the bill. Thank you, Mr. Chairman.